Okay, good evening, everybody. A very warm welcome to everybody who's joining ProMed this evening. Tonight we'll be looking at patient tracking at major incidents. Just going to have a quick little scroll through. We can see that people are from many areas of the UK. We also have 5 people from Europe and 2 people from further afield in the world. So welcome to everybody joining us from around the globe. You can see we have a good mix of staff, clinical grades from first aiders, through first responders, emergency medical technicians, a couple of ambulance technicians, and a few paramedics. We also have some people in here tonight who aren't necessarily from a clinical background. Around about half of you have attended major incidents at scene. A few of you have done some formal training, and a few of you have been in hospitals. So welcome to everybody. I would like you all to participate in the chat this evening. So if there's anything that you agree with, anything that you disagree with, please do have a discussion in the chat. The chat has brought us some fantastic questions and discussion opportunities over the last few weeks, and it's really good to see everybody getting involved. Just as we're going to get started, as you know, ProMed is providing all of these webinars free of charge for you all. However, we do also arrange training courses. We can deliver training courses at your own premises, or we also offer open courses in partnership with one of our training partners based near Aylesbury. So if you're from the SCAS or LAS areas, they're quite close to you. Our next first response emergency care level 3 course will be starting on the 29th of August, and that's going to be running for 3 weekends. So it's 5 days over 3 consecutive weekends. That's a £390, including your ambulance care essentials book to take away. If you're already qualified up to first response emergency care level 3 and you want to go ahead and do your level 4, then we also have that available at £475. That's going to be starting on the 3rd of October. It also runs over weekends, but it's over spaced out weekends to give you time to complete your workbooks. If you're unsure what we mean by the workbooks, do take a look at our website. The link's just appeared in the chat there, thanks to our admin team. It'll explain everything about all of these qualifications, all of the assessments that you need to do to achieve them. We also have the immediate life support, which you need to do annually if you already hold your FREC 4 or if you're a healthcare professional looking to maintain that qualification. We do that for £150 on a Saturday. The next one will be running on the 20th of September near Aylesbury. And if you have FREC 4 and you'd like to do your safe administration of life-saving medications, which I believe is 16 different medications, generally known as the technician drugs or your Schedule 19 drugs, that is running on the 26th and 27th of September, which is a weekend, and we do that for £165 plus the VAT, so it's around about 200 off the top of my head. So everybody attending our webinars and our training events do have a right to a space free from bullying, intimidation, harassment. So please treat everybody with dignity, respect and courtesy and don't discriminate. So if you don't agree with the point that somebody makes, that's absolutely fine. Just be respectful in the chat. Let's ensure that everybody has the opportunity to contribute to the discussion. And if we all learn from each other, it's better than you just listening to my voice all night. So tonight's session is mainly about patient tracking at major incidents. So first of all, we're going to look at from the scene to safety. We're going to be looking at the complete patient journey and all the different routes they can take along that. We're going to discuss the key roles involved in patient tracking from an ambulance and medical and hospital perspective. We're going to be looking at the role that the police force or the constabulary have with regard to patient tracking. We're going to look at what we as event providers or private professionals or even first on scene can do to improvise a solution whilst everybody kind of gears up their full-scale solutions, something to get us started and make sure that we're not losing information as we go. We're going to decide what is essential and what is useful in terms of the information that we're gathering. We're going to look at photography and how that can be of benefit. And then finally, we're going to round off by looking at all the different methods and routes that we're going to communicate this information and any due legal considerations that we might have. Throughout the evening, if you do have any questions, please do post them in the chat. If you don't wish to post them publicly, you can send them to ProMed admin team and they'll be picked up on privately and we will discuss them just without naming you. Towards the end of the evening, there is a Q&A session, so please do hang around for that as well. That's generally where we get a lot of great discussion. So without any further ado, let's have a little look at our patient journeys. Just going to move and switch on our annotation. So this is where we start. We start in this corner here. We start where we find our patient. Now we might find the patient trapped, we might find them walking out of the incident, or if we've arrived, a few minutes after that incident's taken place, then it might well be that we're actually finding them half a mile away from the incident because they've been trying to get away from it. So we say we have an initial found location. The thing with the initial found location is some people will be very keen to get away from that, and they will do this. They will go straight home. They might use public transport, they might use a taxi, they might go and get their car if something's happened in town, but they might go straight home, and we might not actually ever manage to account for everybody that was present in an incident. The most direct thing, and what is hopefully the majority of people, is this particular route down to the Survivor Reception Centre. So for those of you who can't remember, Survivor Reception Centre is what we set up for uninjured persons, people who were present, people who were involved in an incident, but who have got no visible injuries and are not presenting with any kind of concerns. Survivor Reception Centres are managed by the local authority and the police, but we may support them as a medical provider, as we may want a couple of medical staff, because some survivors may have small injuries and may go to say the P3, but likewise we might have some P3s which we downgrade into the Survivor Reception Centre just on the basis that we've treated their minor injuries and we consider that their treatment's concluded. However, they may still need to have their details taken, they may need to be processed, or it might be that they've been displaced from their usual place of residence if their block of flats or their home was involved in the incident. The general plan, however, is from the Survivor Reception Centre, we'll get people to go straight home once they've been processed by the local authority and the police. Thanks to our lovely drip stands and water fairies, we can usually manage to extricate our patients. So anybody who's trapped cannot possibly be a P3 initially. They would automatically be regarded as a P1 or a P2 at triage. So they would need to be extricated from the fire brigade and our heart teams, and they will then make their way to the CCS. So from this whole little area here, we then take everybody into one of the two casualty clearing stations. So generally speaking, we have a majors casualty clearing station, which is for our P1, our immediate, and our P2, which is our urgent types of casualties. And we also tend to set up a separate area for our P3s, which is our minors, our walking wounded. From there, it tends to get very complicated. So the local ambulance service will speak to the local hospitals. They will probably designate a number of receiving hospitals, typically comprising a major trauma centre for the most serious trauma cases, a trauma unit for other casualties, such as your P2s. They may designate other receiving hospitals to receive the walking wounded. They may also put burns units, paediatric units, and other specialist facilities on standby, depending on the nature of the incident and the types of casualties that we're receiving. From our casualty clearing station P1 and P2, it is unfortunate, but it's entirely possible that some patients may well not make it through the casualty clearing station. They would then be sent down to the body holding area, which is just a little annex off the casualty clearing station. Likewise, from our hospitals, unfortunately, with the best care, some patients may be too injured and may also become fatalities. So all of those would then be transported to the hospital mortuary and ultimately end up in the care of the chosen undertakers. Depending on what happens in hospital, what we tend to find with those who survive is they will be, generally speaking, discharged to home. However, if people are more seriously injured, then they may be transferred to their local district general hospital for further care, physiotherapy and rehabilitation before they ultimately end up being discharged to home. Generally speaking, if they've made it to the district general hospital, they're going to survive the overall situation, and that's why there's no arrow down to the mortuary there. So just going to quickly recap what we can all remember from major incidents in general, and let's just take a little look at a couple of questions. So if you're on our previous webinars, you will remember some of these. So question 1 is, which of the following would you use to inform your control room about what you can see in front of you as the first responder from your service to arrive at a major incident? Would you use II March? Would you use Jessup? Would you use methane? Would you use sample? Or would you use Socrates? And our second question is how long is it likely to take before there is a reasonable number of ambulance resources at the scene of a major incident from when it first occurred? Is that 0 to 5 minutes, 6 to 10, 11 to 15, 15 to 20, 20 to 25, or 25 to 30 minutes? You can see I've got about a third of you voted there, so well done for getting involved so quickly. Just going to give a little bit more time for everybody else to have a go at voting. For those of you not seen the questions and answers, we believe there's an issue with polling on the web version of Zoom. So if you are struggling, please can you just privately message ProMed admin team with how you've connected to Zoom, whether it's your phone, if so, what type of phone, if it's a computer, what type of computer, and if it's a web browser, what web browser, just so you can pass that information on to Zoom, because we do use polls every week. Okay, I can see 80% of you voting there. So that's really good. So we're just going to put a little pause on there now. And let's have a look. So well done to 87% of you who chose methane. So just run through them all. So II March is the aid memoir to briefing somebody who is physically turning up to do a role. So it's all about our intentions, the methods, the administration, the humanitarian, the various things that we need to brief people on in terms of what their role is going to be. JESSIP is Joint Emergency Services Interoperability Principles, and that is the kind of joint decision model and the joint doctrine, how everybody works together at the scene. Sample, we'll come on to later this evening anyway. And Socrates, of course, our pain assessment tool. Methane stands for Major Incident Declared or Standby. So major incident declared or standby. We've got the type, hazards, access, egress, number of casualties and emergency services required, and exact location all needs to be said. Now we can do that from the cab of our vehicle, so we don't even need to get out of the vehicle. And then after 5 minutes, after 10 minutes and so on, as more information becomes available in that initial kind of scale up phase, we will provide new full methane reports to make sure that nothing's being missed. Absolutely right from Ruth. It does depend on where you are as to how long a response will take. So we have Manchester City Centre, we know is 15 to 20 minutes. We know London is between 11 to 20 minutes, probably closer to 15 to 20 as well. I would expect in a more rural area, we're looking somewhere between 20 and 30 minutes. Unfortunately, for the 22% of you who believe we're going to have enough ambulance resources in less than 10 minutes, it's been proven through various incidents in the UK in the last sort of 20 years that that's just not possible given the time it takes for everybody to make their phone calls and then dispatch, etc. Just going to clear our annotation. So now everybody has in their mind what the different routes of patient care from the initial where we find them right through to being discharged at home can be. And in particular, once we get out of the casualty clearing station, just notice how complex that then kind of becomes and how many different ways we have of getting them home, depending on the level of care and support that they need to be able to do that. So the key roles involved, first and foremost, we have our primary triage officer. Now, the primary triage officer is the first person who would be responsible for collating any kind of information about casualties. So initially, their focus is on aggregate information: how many priority ones, how many priority twos, how many priority threes, how many survivors, and how many dead have been found. However, once we've got those numbers, the next kind of focus that they need to have is on logging the individual information. So patient ID 1234 is a priority 2 and they're still at scene. Patient ID 3456 is a priority 3 and we've got them sent off to P3. Survivor ID 789 is a survivor and they've been sent off to the survivor reception centre. So they can start to gather that little bit of crude information about the IDs that are on scene, the IDs that have been sent off to a CCS and the IDs that have been sent off to SRC or are otherwise being left there because they're dead. It's nothing that's going to identify the name of a person as yet, but when we eventually do start to link those names to those ID numbers, being able to follow their journey could well be very helpful in terms of reuniting them with their possessions, reuniting them with their body parts, and providing appropriate information to the police who might want to be conducting an investigation. Next up, we have the officers based in the casualty clearing station. So the casualty clearing station officers are going to be responsible for coordinating all of the activity within the casualty clearing stations, and that is ensuring that there is some kind of management of the patient tracking system. That, in the main, will be falling down to the secondary triage officers and the ambulance loading officers. So the secondary triage officer, hopefully by the time they're getting swamped with casualties, they've had a few moments where they're able to think about what system they're going to use. As a minimum, they should be logging the ID number of that patient that comes through the door, what priority they are, and whereabouts in the casualty clearing station they've been allocated, and preferably the time that they're first encountering them. At the back door, the ambulance loading officer needs to ensure that they're logging the patient's ID number, the destination that they're going to be sent off to, which crew or vehicle ID is going to be taking them, and again, the time that resource has left scene with that patient, just so we can start to build up a picture of how long patients are spending in certain areas, and also how many patients and which patients are going off to which hospitals. Again, it doesn't necessarily matter at this time if we've been able to reconcile that against any patient names or other data, but by having the ID number against which hospital they've gone to, as more information emerges and we kind of track and trace that together, it just means that we can then make sure we get relatives going to the right hospitals and so on and so forth. At the hospital, we'll have our hospital ambulance liaison officers. I'm sure many of you who work frontline will be well used to seeing them at most of the key hospitals now. They basically just transition straight from their normal role into a much more of a meter and greeter by the door role. So we need to be making sure that ambulance loading officers are communicating with those halos. We need to make sure that the number of patients coming to them, the priority of patients coming to them is constantly being passed over. And then they need to be reconciling the information. So as a patient comes through the door, okay, your crew 1, 2, 3, I'm expecting you to have patients 4, 5, 6, 5, 6, 7, and 7, 8, 9 on board. Is that correct? Yes, it is. Right, I'm going to tick all them off. You've not lost any patients on the way. Take them straight in. And that just means because we've got a set of information leaving the casualty clearing station and a set of information at the hospital, if they both match, then we know we've got a good verifiable data set. Then quite importantly, inside hospitals, we've got ward clerks. So for those of you who spend a lot of time in hospitals, the ward clerks, the receptionists, they're the people who will make sure that the information being passed to them by the ambulance service or the walking wounded, they'll be asked the appropriate questions. So this is the point when we start to gather patient names, dates of births, addresses. What ward clerks need to be really mindful of is in a major incident situation, they need to make sure that all the details they're obtaining, somewhere on those details is the major incident triage tag number. Let's just have a little look. We've got no further questions on that. So the next thing we're going to be looking at is the role of the police. So let's just have a look and see what do we all think the police do at a major incident. So you can select as many of these as you want. Do you think they're going to secure the overall scene? Could they collate records of casualties? Could they manage access routes? Will they be informing relatives of fatalities? And could they assist with moving casualties to hospital? So which of those do you believe that the police are going to do at a major incident? Can see the vast majority of you have voted there, so I'll just give it a couple of more seconds for anybody else who wants to have a go at that question. Okay, let's pop these results back out to you there. So absolutely right. Everybody almost is saying that the police are going to secure the overall scene. So yes, they are going to be at the cordon, making sure that members of the public can't wander through, making sure that the media are kept in their designated area, which for us helps to ensure that patients' privacy and dignity is protected. And it also means that we have a little space away from the public eye, because we need to make sure that in any incident, we're taking care of our own welfare, our own well-being, and our own mental health. The next most popular answer was managing access routes. Absolutely. The police traffic team will be making sure that we have a nice run in and out of the major incident, so that we're not getting caught up in traffic and that we have a nice clear route through to our hospitals. Police do inform relatives of fatalities. They also collate records of casualties, and they assist moving casualties to hospital. So let's take a little bit more of a detailed look at what they're doing. So the first thing that the police are going to do away from the scene is going to be to set up a casualty bureau. So the casualty bureau is an automatic activation of the National Mutual Aid System, because if there's a casualty bureau in one force which is already dealing with a major incident, they will almost inevitably need support from other forces to answer the phones and start recording information whilst they're still busy with the actual incident itself. There is a National Mutual Aid telephony system, so that's why you see all these numbers that appear on the TV at a major incident, and that will ring all the police forces connected and participating in that particular incident, and it'll just be answered by the first person available wherever they are in the country. At least then the relatives can speak to somebody as a person rather than necessarily just listening to a pre-recorded piece of information. If they believe somebody's involved in the incident, they can pass over their details, what they look like, what their name is, where they were likely to be, and then the police can start using that information to reconcile against what we've provided them. So what the Casualty Bureau actually is it is a collation of casualty, survivor and evacuee records for relevant parties. Now, those relevant parties obviously include the ambulance service, the local authority and hospitals. It also traces and identifies people involved in an incident. So if we have information as to who's there, then it will be able to identify who they are based on various different record sets. Likewise, based on information passed by relatives, we can trace who was and who wasn't actually involved. And the Casualty Bureau sits within what's called disaster victim identification. So DVI is something that all police forces do, whether it's a small disaster involving one or two people, or whether it's a multi-victim disaster where there could be hundreds or even thousands of injured people, fatalities, or even survivors, anybody who's been caught up in that disaster. It's the police's responsibility to kind of bring all that together. And then the police have the family liaison team. Now, depending on where the incident takes place, this might not just be the family liaison team of the local police force. This could be family liaison teams for police forces and constabularies across the whole of the country. And through the Foreign and Commonwealth Office, it could even be police forces in other countries. If it's a plane, for example, then there may well be international people. If it's a multinational sports tournament, then there's likely to be a lot of international spectators. So the police, through the Foreign and Commonwealth Office, would speak to police forces in other countries, and the family liaison teams there would also be involved. Depending on the size, scale and severity of the incident, it's not necessarily just fatalities that family liaison teams deal with. They may also go and personally attend the relative of a seriously injured victim and explain face-to-face, in person, what's happened and what their injuries are, rather than it being a faceless phone call from somebody who they can't really see. So, police force do have a really strong role to play when it comes to uniting families with their relations and tracking all of that information together. From a medical provider or an ambulance service perspective, one of the things that we need to be doing is making sure that we are keeping comprehensive records and that we are sharing them with the police. The more comprehensive and accurate and timely those records are, the quicker the police can perform their duties in terms of getting relatives to patients and making sure that relatives aren't waiting a long time for information. I've never had a relative in an incident, although living in Manchester and, Manchester having been in the news for various incidents, my mother has personally worried about me. And, in my case, I've never been involved in them. I've been able to message her and say I'm fine. But had I been caught up in the incident, I'd have been relying on the police to be able to tell her that, I'm injured, but I'm okay. I can only imagine what she would go through if if I wasn't able to communicate with her. So as a medical provider, I always ensure that in the plans that I have for events, if things do go wrong, that we have a process in place for record keeping and ensuring that those records are passed to the police in a very timely manner so that they can do their job and stop people worrying unnecessarily. And that brings me on to what I've termed a rapidly deployable improvised solution. So what we have is we have Google Sheets. So I'm just going to switch across to our Google Sheet now. So I'm hoping, and if somebody could just respond in the chat to let me know, I'm hoping that you can all now see Google Sheets on your screen. Yes, fantastic. Okay, so what I've devised is just a really quick, simple spreadsheet. So this is set up so that anybody who's got a promed999.co.uk email address can literally go to our Google Drive, type in major incident, and this will be the first thing that comes up. They all automatically have view access, and they can click one button and request edit access. Also, very quickly and easily, all I do is click share, and then I can start typing in as many email addresses as I want. Click done, and then that sends everybody. Oh, I've just noticed actually everybody in ProMed can edit this document straight away. We can also get this link nice and visible just by copy and pasting and sending that out. So I'll go on to how we communicate that quite quickly. So we've got various columns set up on here. And first of all, we have an identification section. So the first column is quick ID. So before we even have triage tags, quite often people will be using marker pens and Sharpies. So you could have triage officer A, triage officer B, triage officer C, triage officer D, and so on and so forth. And then each person would then start at number 1 and go up to, however far they get. So A1 is the first patient. We also know that they triaged, so they dealt with 2, they did 3, they did 4. We also have person B, and so on and so forth. So we've quickly done that, and now someone's came running up from the first aid post with their triage tags, and they've gone, right, okay, I'm going to give everybody a triage tag. I'll fold it to what that first person who triaged them did. So let's write down our triage tag numbers. And so on and so forth. So this will continue all the way along. Now, in the initial phases of an incident, we're not going to have the hospital ID and we're not going to have the NHS number. That comes much later in the process. So we also know our initial priorities. So there could be a P1, there could be a P1, there could be a P3. We're going to have lots of P3s and we've got one P2. So where are they? Well, our P3s were walking. We know this because P3s walk. So our P2 could be under stage. Our P1 could be on stage. Our P1 could be on stage. So, and already we're starting to collate information. What do we need for this to happen? We need a pen and a piece of paper. We need everybody who's triaging just to quickly make a note of the ID number that they gave that patient, what priority they were, and where they found them. So the way that I would do this is I would literally take a pen and a piece of paper and I would write down the area I'm triaging. So if it's a train, I might write down carriage A because that's where I've been told to go. So I would just write down 1 P1, 2 P1, 3 P3, 4 P3, and so on. And that's enough to start with. I will then pass that piece of paper to someone and then they can do this. Next step is optional. So delayed and extrication is entirely optional. So all I'm doing here is just making a note of any change in triage priority. So in terms of delayed, yep, they're not delayed. P2, however, they're trapped under the stage. So I'm going to re-triage them later. They're still a P2. And then the fire brigade come along and extricate them. And actually, once they've been extricated, their legs are in perfectly good order. They were just trapped by their arm, for example, and they decide to walk. Awesome. Makes our life easier. No lifting. So now we move up to triage short. So this is now when we're arriving at the casualty clearing station. What we're doing is we're just making a note of that patient's priority. So majors, minors. Oops, we've not typed that in yet. So it's just a location of where they're going. And then in the CCS, we know that priorities might change based on anatomical information and so on and so forth. Now the important bit. So we now have a triage tag ID, and the ambulance liaison officer is going to send them off to hospital. So I'm just going to put major trauma centre. They're going to walk-in centre. They were sent off to minor injuries. They were actually allowed to go home, and they were sent to a trauma unit. A hospital entry, again, we're just going to re-triage them, and so on and so forth. So in A&E, that's just a re-triage. Surgery is just a re-triage. Theatre, so which theatre did they go to? Well, you went to theatre 3, you went to theatre 2. Ward, so what triage are they now? Well, you're now a P2 because your surgery was successful. You're a P1 because you're still critical. What ward number are you on? Okay, you went to 84, which is general surgery. You went to 82, which could be cardiothoracic surgery. So we're now just keeping track of where all these patients are. However, our minor injuries, we've now managed to start getting some information out of them. Now, how we get that information out of, I'll come on to a little bit later, but we can start to record this now we've got it. So we've got Joe Blogs, we've got Jane Smith, and we've got Josephine Blogs. And as they'll go along, you will see that we've got much more information about the patient. We've then got sample, so the signs and symptoms, what's wrong with the patient. Any allergies they've told us about, any medication they take, any history they have, last oral intake, any exposure. And then the photograph column is if we're managing to get a photograph of any injuries they have or their face, we're just going to make a note of what that file name is. So you're 123.jpg. We haven't got one for you. But we did get one for you. That's your file name. So that way we can identify who is who. And that's all we've got. Now, the intention behind this is, as we're filming it in and people turn up and people need access to this information, we would then send it to at nhs.uk, at police.pnn.uk, or whatever official email address. We're not going to give it to a paramedic, paramedic123@gmail.com. Perhaps not the best idea because we don't necessarily know that is definitely them. We would only ever share this with verifiable email addresses. Now, I can see that there is somebody saying information governance. So the reason why it's available to everyone in ProMed, well, it's not available to everyone in ProMed. It's available to people with promed999.co.uk email addresses, which is only our office staff and leadership team. So it's a very small number of people, all of whom have signed the appropriate confidentiality agreements and who are bound by their usual contracts. And the reason why we want office staff to have access to it is because of the second part of what we do. So I'm just going to go back to our presentation, and this is where our second part comes in. So all of our events already have a WhatsApp group. So if you're working for ProMed or on an event where there's kind of 3 or more people, there'll be a WhatsApp group set up, and any communication to do with that event will just happen in the WhatsApp group. So the idea is, if anything did go truly badly wrong and we had a major incident, then those notes, all I would want anybody on the ground to do is take a photograph of their notes, put it in the WhatsApp group. Whoever the event manager is just needs to remember to add the people in the office who aren't currently at the event into that group, and then they can start processing all of that data and putting it onto the spreadsheet. Now, if you've not came across WhatsApp Web or WhatsApp Desktop, have a little Google search for them later on. Download the desktop version if you want, or just try web.whatsapp.com. And what you'll find is it gives you a little QR code. You can scan that from within WhatsApp on your phone, and it links the two together. So only while your phone has a data connection will it allow you to use it. And what it does is it just basically puts everything on your WhatsApp on your phone, on a web browser, or on your desktop. So it's a lot easier to work with. So if you've got a couple of screens like I have, you'll have WhatsApp open on one, and you'll have your spreadsheet open on the other. And then that way, those who are at the incident can focus on doing their job and just making a few scribbles, and then just photograph them scribbles, and then somebody else can process that into a much more meaningful way. Or as we get more and more resources on scene, if they've got a laptop, they can literally just be given that piece of paper and they can then start working on typing that up and starting to keep that accurate flow. Let's have a little look. So the template, so admin team are just going to put something in the chat saying if you want the template, email us. I am happy to share that template. And Andy, you're absolutely right. So everybody who is at an incident is a witness. You are 100% correct. So we, as a general rule, everybody who walks out of that incident gets a triage tag. Remember that triage tags are also given to those who we define as dead from triage save. Those who become fatalities in the casualty clearing station should already have their tag. Those who are survivors, i.e. walk out and do not complain of any injuries, do not visibly have any injuries, still should get a survivor triage tag, which should have an identification number on it. So all of those should be tracked. It might just be that we have a record that we gave a tag out because that person's made their own way home. But at least it gives us an idea of the numbers. At least that means for the police, okay, actually there were more people. We need to look at the CCTV and so on and so forth. Antonia, yes, absolutely. So how do we share the information live at the incident? So I'll quickly go back to that. So new share, major incident tracking. So all I would do is I would ring my guys at the office, or I would even do this from my phone because Google Drive is amazing. I can do it from my phone. Click on share, and I would start typing in. So let's have a look. Dispatch at east.nhs.uk. That's probably not a real email address. Silver, oops, again, very bad. So we could also just do silver command at las.nhs.uk. It notifies them message to do with the incident on the M25 right now. And then I would just click send. Obviously, I'm not going to, but that's how quickly and easily I would do it. Likewise, I could send that to the police. Likewise, I could send that to the fire service, the local authority liaison officer, anybody who had a legitimate need could have that. And likewise, any hospitals, halos, people responsible for collating that information, adding to it, absolutely could just very quickly be added to it. So yes, you could get that information to the scene commander in exactly the same way. And again, this is available on your mobile phone. So I've just remembered something else I didn't show you on that. So I'm just going to go back to it. So it's already set up for filtering. So, okay, let's have a look. I want to know how many P1s I've got. There you go. That is now only showing me my P1s. And I can go back to all there. I want to know how many are coming to me at the major incident unit. There you go. That's which patients are coming to me at the major trauma centre as the halo. Now, it would be great if everybody had laptops, of course, and could see this in full, but you can do this on your mobile phone. If you've downloaded Google Drive, you can access our spreadsheet on your mobile phone. A little bit trickier to edit, as you all know what mobile phones are like, but in terms of viewing the data and filtering the data, it's already set up to filter on any criteria you want to filter on. You can also sort them by priority. So I want to sort them by name. So there you go, there's the names at the top in name order. If we popped some ages in there, we could sort them in age order. You can select, you can filter. It's the same as any spreadsheet. Just because it's on Google doesn't make any difference. If you can use Excel, you can use Google Sheets. So going back to our slideshow there. So as I say, the initial kind of response is the WhatsApp groups that we already have set up, and then that kind of is then administrated into the Google Sheets. So before we move any further, I just kind of want to gauge everybody's opinion. What do you What do you think in terms of a really simple cloud-based, simple spreadsheet combined with a WhatsApp group as a quick way to start collating that information? Do you think it's a good idea? Do you think it's a good idea, but you've got some reservations? Are you a bit unsure? Do you think it's not a good idea, or do you think it's not a good idea, but you kind of would look a little bit more into it? And again, this is an interim thing only until everything is then handed over to the police, who then start their normal casualty bureau and full tracking management system. But remembering that the police could well be 20 to 30 minutes away before they get there, and then probably a further hour before they have a basic casualty bureau system operating. So this is the first 90 minutes of making sure we're not losing any data, basically. So 3/4 of you voted really quickly there. Thank you very much. Anybody else to vote? We're just going to end it and share it straight back to you when you all have. So Dave, cell site saturation, remote areas, poor coverage. You're absolutely right. So backups, we'll look at some other ways of getting information across towards the end. That'll be on our last slide. Michael, scanning barcodes into Google Sheets via a smartphone camera. You have taught me something new today. I wasn't aware you could do that. Guess he's going to be having a play with that with some random barcodes in his house tonight. Pete, yeah, you're absolutely right. It is an initial starting point. And you're right, if telecoms are swamped, you might well struggle to get that information on site, or you might struggle to upload that information on site. But at the moment, typing it into an airwave terminal takes forever, and it's probably not going to happen. It would only happen by voice. So this is it's a yes, it's okay. Also, the thing that I like about Google is Google has a kind of asynchronicity to it. So if I type stuff on my phone but don't have an internet connection, it will version control it locally, and it will then merge that version control into the web when I have a connection. And where there's a conflict, it will just highlight the conflict when I'm online, and then I can work out how I want to resolve that. Not every cloud-based solution does that, I will say, but there are good cloud-based solutions out there that have that kind of version control management. You're right, Neil, once everybody starts phoning mum, and you're right, live streaming videos on Twitter and Facebook and Instagram, cell towers do get overloaded. Michael, yep, that's something we're going to talk about. So it is one sheet that everybody edits. Kim, it is one single sheet, because Google is really, really good. If you've got people editing it at the same time, every person gets a different colored label, and you can see which cell that everybody's working in. So you don't work well, so you can see what people are working on, and you know not to work on the same cell as they. But it also has conflict control. So if you select a cell that somebody else is already using, it kind of says, are you sure? This will create a conflict. Andy, so a written log, a handwritten log on a durable piece of paper with a ballpoint pen and ink is legal, and cannot easily be changed. However, there are Tipexes out there that is very, makes, you can almost write back over a pen in white ink almost. So yeah, they're more or less foolproof. However, what I like about Google Sheets, and the reason I use it, is it has full version control. Literally every edit you make is saved in an audit log. It's not the easiest to get at as an end user, but on the desktop version, you certainly can literally go into it and go through it. But Google does make it available when it is demanded of them. It will literally give them, user login 123@gmail.com, edited cell A4, changed it from 456 to 457 on Thursday, the 13th of August, 2020 at 1945. Michael Clark, yep, we'll go into that later. Pete B, yeah, so it is, yeah, it's like Dropbox, a local document synced with a cloud version. So basically, Google's, and it's it says it's entirely in the cloud. You can actually make it available offline within Chrome. If you've got Drive on your phone, it will save a local cache copy as long as you've already downloaded it. And Michael, as you've exactly said, so yeah, Kim and Michael, yeah, absolutely. Everything that you do in Google Sheets is audited, logged, who did it, what time they did it, what they did, and if there's a conflict, it presents the conflict to you and asks you to how you want to resolve it. If it is something you're interested in, do email us. We will happily send you either a link to, we'll set up a dummy copy and we'll share it so we can all have a play. We might even do another webinar session where everybody actually does it live and we can see what's happening live. We will send you a copy that you can download, save yourself and have a play with. But obviously you can research yourself, just look up, how does Google Sheets work, Google Sheets version control, Google Sheets auditing and so on, and you'll be able to find all that information out. So now we're going to look at information gathering. So let's just go into our next question. So I've got a few different things popped up on your screen now. So which of the following would you regard as being essential as opposed to being useful when it comes to patient tracking? So do you think it's essential that we have the unique ID number, which is a triage tag? Is it essential to have the casualty's full name? Is it essential to know if they're alive, dead, injured, uninjured, etc.? Is it essential to have their age and their date of birth? Is it essential to know where that casualty currently is? Is it essential to know their resident address? Is it essential to know the name and contact number for their next of kin? Is it essential to know their sex and gender? Is it essential to know their ethnicity? Is it essential to know their current medication, allergies, and medical conditions? So when it comes to patient tracking, which of the following are essential as opposed to useful? Alexander, thanks for letting me know that it is only allowing one choice. It should have been set as multiple choice, so we do apologise. Pick whichever one is your favourite. Okay, let's just run through these. So a unique ID number, whether that's from a triage tag or another triage process, absolutely is essential. That is what we are using as our one identifier for that patient. Their full name, let's wait and see about that one. Whether they're alive, dead, injured, uninjured, etc. So that their current status, if you will, is essential information. Their age and date of birth, perhaps. Where that casualty is currently located, we would be regarding that as essential. Nobody's put their usual resident address, absolutely not essential. Name and contact number for their next of kin, we'll have a look at that. Their sex and gender, again, we'll have a little look at that. Same for their ethnicity, we'll have a little look at it. And their current medication, allergies, and medical conditions, but we'll see whether we regard that as essential or useful in a moment. So thank you everyone for having a little go at that question. So, as we've just said, the person unique identifier is absolutely essential. That is the one kind of record set, that one record we're going to use to know who is who. So the status of that person, whether they are alive or dead, whether they are injured or uninjured, is essential information. If we've got a vague idea of what their status is, we can then provide timely information, be that to our onward care provider, be that to the aggregate figures, be that to their relatives. The location of that person, so whether they're at scene, CCS, ambulance, hospital, etc. So if we just think about that spreadsheet that we had there, if we've got records of how many have been secondary triaged at CCS, we can have a look at how many are still left on scene. If we know how many have been put into ambulances, we can see how many we're expecting shortly at receiving hospitals. We can also work out how many are left either overall at scene or within the CCS. So by having that information against each individual, firstly, we can ensure we've got reliable aggregate information, which helps us with our resource planning and our bed management. But secondly, if we have managed to identify that person more conventionally and we receive or the police receive an inquiry about them, we can then provide timely information to their relatives. So, yes, we do know that Joe Smith has been caught up. They're still at the scene. They're being worked on by the ambulance and fire brigade, but they will be brought out as soon as possible. Or Mrs. Smith, you're asking about. Yes, we know that Mrs. Smith has gone to the Royal London Hospital. Unfortunately, they're not accepting visitors at the moment, but I will take a note of your name and contact number, and when they are ready to receive visitors, we'll give you a phone call and you'll be able to go and visit them at the Royal London later. So if we know where patients are, we can ensure that relatives are kept updated as to their condition. We want to know the approximate demographics, so their age, their height, their build, their ethnicity, their sex, whether they're pregnant or not, if they're female, eye colour, hair colour, anything that we can see. So we're not necessarily reliant on getting their name. We're not necessarily reliant on knowing anything about them, because our patients may be unresponsive. It may be that they've been sedated. It may be that they're a fatality. So we're not necessarily going to get that information out of the patient. But if we can get these demographics, then the police are very good when they're, when somebody says, I'm looking for James. Well, who's James? James Smith. Yeah, okay. Well, we've got a few of them. Do you want to describe James to me? Yeah, he's a 24-year-old male. He's 6 foot tall. He's white British. He's quite well built, quite muscly. He goes to the gym a lot. He's got blue eyes and he's got short dark hair. He's got a nice goatee, really long-handled mustache. That gives us something to go on, because if we find someone matching that description, whilst we aren't going to certainly say that is that person, it means the police, if they can't find two of that match, they're likely to say, well, would you like to come down to hospital and we'll see if you recognize that person from a photograph. It's a starting point for matching. So if we can record that information whilst we're treating them, then great. If we've got people who are non-clinical who are available to help us, they can be tasked with writing this down. They can be tasked with going around patients, obtaining information. Whether that patient's able to speak or not, we don't need them to speak to gather this information. So let's have a little look in terms of what we consider to be useful then. So the patient's full name and their date of birth is absolutely what we regard as useful. So a full name and date of birth will usually manage to get a positive return on the NHS database. It might well still not isolate it to one patient. However, it's a really good start in terms of being able to get an identifier from that person. Same police, and when they search the police national computer, that's the minimum information set that they'll want to conduct a search. It's also helpful in terms of providing care. If we know that patient's name, we're able to address them by their name. And as I'm sure you know, just a reminder, introduce yourself to your patient. Hello, my name's Matt. I'm with the ambulance service. What's your name, please? Just make sure that any care we're providing is on a personal level. So even if that patient is unresponsive, if we do know their name, I'll still introduce myself to an unresponsive patient, because it might be that they can still hear me. And I do ensure that everybody in ProMed prides themselves on delivering quality care, and that includes personal introductions and addressing patients by their preferred name. So it might be that Jane Smith wants to be called Mrs. Smith, and we'll address her by Mrs. Smith. So we need to make sure that we get a full name to do that. We might want to know about their current medication, any medical conditions and any allergies. Obviously, that patient may well need surgery. It may be that they need to be RSI'd at some point. It may be that their condition deteriorates between now and hospital and they're unable to provide that information later on down the chain. Their usual resident address is what we'll use to verify the record that was found against their full name and date of birth is the correct record. It's those three as a combination that almost guarantees we've got it correct. It also means that if we do need a next of kin, if we do need a door knock and we've got no further information, by having that usual resident address, the police have got somewhere to go and knock on a door. If the patient is conscious, or if we have access to their phone, so ICE, for those who don't know, in case of emergency, or the medical information section on mobile phones. If you have a mobile phone and you've not set your emergency ID or medical information or whatever it's called, I strongly urge you to do that and make sure that you have an ICE contact programmed in it. But again, if we have spare hands who are going around and doing administrative duties for us, I will be asking them to either obtain that from conscious patients, or if we can confirm a form belongs to an unresponsive patient, see if that information is there, write it down on a piece of paper. And that's because mobile phones can become damaged or their batteries can die, and then we wouldn't have that information. So in situations like this, it's important to try and get pen to paper as much as possible, I do say. And that's it, really. We don't want to go beyond that. Now, if we have a little think, if we post some ideas in the chat, what ways have we got of gathering this information? So how are we going to manage to get this information and get it recorded? What do people think? How can we go about doing that? So, yep, Ruth, we can check for medical ID. We can also check for medical talismans. We can do things like that. Emma and Michael, great combination of ideas there. So stuff going into the WhatsApp group, whether it's photographs, whether it's typed stuff. Yeah, we can take a photo of a driving license and then just pop a couple of comments underneath to say, this is patient 1234, and then that provides that. If they aren't unconscious, just ask them. Wallets, purses, necklaces, bracelets, asking them, patients' phone, any friends with them, medical ID, ask patients and bystanders. So all some really great ideas. So now let's look at it from a different perspective. There is 100 casualties and there are only 20 of us at the moment. We're busy triaging, we're moving patients down to CCS, but quite a lot of our patients are awake, they're talking to us. What can we do? Absolutely, Caroline. If there's a plane manifest, a hotel guest list, if they're part of an organised event, if they're part of a pre-booked transport, then we can arrange to have those lists printed off and sent to us. Pete, triage cards have a section to scribble it in so it tracks and travels with the patient. So thinking along those lines, what are we going to do if there's not many of us, but there appears to be a lot of conscious people at our incident? There we go, Emma, well done. Ask the patients to write their own details down. Ask them to make their own way if they're alert and well. The ones that can walk, send over a waiting area. Yep, get the ones that can move themselves away from the area, give them a triage tag, fold it to number 3, and give them a pen and say, please, can you write down your full name, date of birth, address, and everything else that you know on the sections in this form for me. That way we don't have to do it. And if their condition happens to deteriorate later on down the line, then we can do that. And then all we need is one admin person to just take a little photo of that page onto the WhatsApp, and then somebody can pop all that into admin, into the spreadsheet. That's then available to everybody, i.e. the police and ambulance service who need to see that to start collating information. So when inquiries are received, do you know if Joe Bloggs is alive? Oh, actually, yes, Joe Bloggs, yes, we have a record for them. We know that they're currently in Miners Casualty Clearing Station, awaiting a nice large coach to take them up to a minor injuries unit to be cleared. If patients can do things themselves, absolutely get the patient to do it themselves. If patients can't write, but there are other patients who can, then give them a little job to do, especially if we've got uninjured bystanders looking for things to do. Give them a pen and say, can you go around everybody and see this page here where it says name, address, date of birth, medical conditions? Just ask them, and can you write it in for them? That's great. You're doing a really fantastic job. Thank you very much. They feel valued. They feel responsible. They've got something to do, and you've not got a bystander that you're tripping over because they've got nothing to do. So the relevance photographs, I am unashamedly going to be citing Grey's Anatomy. So if you've who's watched Grey's Anatomy, particularly the early episodes, season 3, give me a little wave in the chat. Type if you have. Who's watched Grey's Anatomy, the earlier ones? Who knows what I'm going to go to now? Yep, unfortunately. Yep, so there's a few of you who know exactly what I'm going to say. So there are many reasons why we want photographs. First of all, the police are going to want to know where patients or where bodies are found on scene. Now, as an ambulance service, we want our alive patients to be removed from scene nice and quickly. We want them into casualty clearing stations, into ambulances and into hospitals nice and quick. The police, on the other hand, want to know where everybody was right after the incident so that they can start trying to match up witness statements to different perspectives and angles of the scene. They want to know how the scene looked before we started kind of dragging things and moving things around. So if we have time, if we have our phones in our hands as we're approaching scene, there's nothing wrong with having it on video or having it on photo, as long as what you're doing that for is for relevant purposes. If you're doing that because in a couple of weeks' time you want to post that on social media, or after your shift you want to share that with all your mates, absolutely not on. If you're doing it because you know you're about to ask everybody to stand up and walk away from the scene, but the police are going to want to know who was where at the beginning, and all you're going to do with that is email it to the police officer and then delete it from your phone, then that's absolutely fine. Absolutely, Michael. If your phone's got your location services enabled and you've enabled it in your settings, then your photograph will have a geotag on it. So if you take a photo, it knows where you were stood, and then if you can identify who's in the photo, you know where they are. And the police and the other agencies can then start to build up an overall picture, and then that can be tied into the witness statement, so that if somebody at this side of the event is saying one thing, but somebody over here is saying something different, that could actually both be true because they both had different perspectives. If, however, somebody's here and somebody's here and they've both got very different stories, that's unlikely because they both have the same perspective. So it's quite useful for the police to be able to see where people were and have that independently confirmed, because again, what you've got to remember is in traumatic incidents, people not choose what to remember, but people's brains remember certain things and don't remember other things. And certain periods of time are more remembered than other periods of time. And one of the things that people don't actually remember is where they were when something happened. They remember what happened, but they don't actually remember where they were. Or they can remember seeing somebody, but they can't remember how that person got there. So having that kind of independent visual record is really good for later investigation and inquiry. It's obviously never going to be our primary focus, but it might be something that we can very quickly and easily do. The other thing that we really want to use it for is keeping a record of injuries before any initial treatment and packaging. Pete, absolutely right. You don't remember everything at a time, but your brain tries to fill in the blanks. So your brain remembers something, but then it doesn't remember 2 minutes. Then it remembers 2 minutes. Then it doesn't remember a minute. Then it remembers the next 10 seconds. Then it doesn't remember 2 minutes. And your brain just tries to go, well, this is what happened then. This is what happened then. So obviously this must have happened before that. That must have happened after that. So what must have happened in the middle? Well, and then it kind of tries to put a story together. And as you say, sometimes it is able to reprocess and it does regain the memory of the full sequence. But other times that full sequence is never there, and it's only your brain's interpretation of that missing gap, if you will. So going back to what I was just moving on to there, you've got a record of injuries before initial treatment and packaging. So if you've extricated somebody and they've got a serious injury, you have dressed it as best you can, you've then immobilized the injury, you've then put some bubble wrap over them, you've put them into a scoop, you've strapped them onto that scoop, you've put them onto a stretcher. Do you really want them going into hospital with their mechanism of injury and the doctor going, well, what's wrong with them? Well, it says they've got this injury. Okay, great. Let's have a look at it. So we then take the scoop off them, we remove all that bubble wrap by cutting through it so they start to get a bit cool again. We then 90-degree log roll them just so the doctor can have a look at their back. When actually, if we'd taken a photograph of that, the doctor can go, oh, right, yeah, oh, I can see that does look like, a bit of an interesting bump. I can see that discoloration. Yes, absolutely, that patient is going to need surgery. It just saves unnecessary handling and exposure of a patient if we've got a very accurate and then more importantly visual record of that patient's injuries, because it means we're not needing to expose wounds. It means we're not needing to expose fractures to the open air because we have that information to hand. And then lastly is the identification of survivors, victims and deceased. And this is where my Grey's Anatomy citation comes in. So for those who can remember season 3, episodes 15 and 16, there was the ferry crash. The clinic was crowded with worried families, so it was basically the relatives reception area. And Alex, one of the young doctors, is yelled at by the families because he's not got any new information, and he yells at them back to be quiet because he doesn't know anything, and he needs time to come up with a system. So what he does is he sees this instant little Polaroid camera, he grabs that, and he goes literally every single patient he can find in surgery, in the emergency room, in a ward that came from the incident. He takes a photo of them, and he writes their ID number on the back of that photo, as well as where they are, and he takes them down, he starts pinning them on the board, and then people can, recognize, yes, this is my daughter, she's called Mary, yes, this is my son, he's called John, and so on and so forth. And it starts to allow that reconciliation of an unidentified victim with a family looking for their relative who believed to have been in the incident. How do you ensure that a chain of photos follow from the site of injury to crews, ambulance has been taken to A&E? Again, I go back to my WhatsApp group. You just simply put the patient's ID number with the photo, admin save that photo, and put the saved photo number against their records, or saved photo numbers if there's multiple photos against their records. And then if they need them photos, somebody from A&E can then ring a central number and say, I've got patient, 1, 2, 3, 4. Somebody's wrote photo on their form. Do you have their photos? Yes. Okay. What's your NHS email address? They're coming over to you now. Could be something like that. It could be that it is literally emailed from person to person as it goes along. Ultimately, it depends on the solution that people come up with. Do we need to ask the patient before taking the pictures? So if they are conscious and they have capacity, absolutely, we should be asking their consent before we do anything. We should be asking their consent before we treat them. We should be asking their consent before we take information from them. We should be asking their consent before we take a photograph of them. If they don't have the capacity to consent, so that could be by way of being unresponsive, that could be by way of the seriousness of their injuries, by way of their age, intoxication, impairment of their mental health, learning difficulty, or any other reason why they don't at that moment in time have capacity, then we need to take what's called a best interest decision. So again, if you're unsure of how to do capacity, how to do consent, and how to use best interests, then do your own CPD, have a little look online, do your own research. There is plenty out there on that process. In the situation of a major incident where we have somebody who is unresponsive or unable to communicate properly, or is distressed and doesn't have capacity, and isn't with anybody, it is arguably in their best interests that we take their photo and that we use that photo in a responsible manner to allow them to be reunited with their next of kin, with their loved ones, who will be able to provide calm and reassurance to them. So it's being careful. If you're filming the incident scene, no. So a couple of little tricky points. Legally, you don't actually need any permission to take a photograph in a public place or record a video in a public place. However, the scene of a major incident is governed by various different laws. The police would regard it as a crime scene, and they have various things they can use to prevent you from doing that. However, as an emergency responder, doing it for the purposes of patient care, if that's for a wound management later down the line, or injury management later down the line, that's absolutely fine. If you're doing it as part of an identification process, then we need to make sure that is being used responsibly. And then lastly, we're going to look at communication methods and routes. So I would say the most common communication method at a major incident overall will be the telephone. That is the telephone to the casualty bureau. That is the telephone to individual casualties or survivors on the scene. That is the telephone between ourselves and others. The telephone is very heavily used. and that does lead to networks becoming over capacity. Emergency services do have radios, they do have airwave. They are generally less subject to capacity issues. Don't assume that means they're not subject to capacity issues, depending on where your incident takes place. If it's only covered by 1 or 2 airwave cells, you might very well find that once you've got all responding agencies on scene, especially if some of them are still using their ordinary talk groups, there is a phenomenon called talk group dragging, and that just means the local cell sites get overpopulated because there are too many talk groups in use, and therefore that cell site is saturated, and then somebody who is trying to use the next talk group isn't available. Michael, ACOLC, still available, yes. However, less and less handsets are getting ACOLC enabled on them. There are commanders who will have ACOLC. There are command vehicles with ACOLC, and that's about it these days. And therefore, that is almost as it's debatable now whether ACOLC is more or less of a limitation than not. Because if you're only allowing commanders and command units to communicate, then actually what you're not allowing is all of your responders to communicate. You're not allowing the public to communicate, which is, yeah, usually that is a good thing. But if you're not actually allowing your own responders to communicate, then you could end up with, you could actually end up getting less information overall. So it's a risks and benefits, and it is something to consider carefully. Yeah, it is MTPS, sorry. Yes, and yeah, it is a pain in the backside getting the Home Office and the appropriate people to sign off on it. There are, however, other mechanisms that carriers could use. Speak to them very nicely. You're right, MTPass will be used a lot once 4G ESN goes live. So for those who don't know, 4G ESN is the emergency services network, which runs on a 4G infrastructure backbone across the UK. So it is a single provider that is responsible for it, but they do have protected frequency space compared to the commercial provision that they have. But in the case of a major incident, the commercial space that normal customers can use have it. It's going to enable the emergency services to have full data connections, be that video, be that text, be that voice. It's all going to be done by data, and it gives them guaranteed bandwidth to every handset wherever they are in the UK. So in terms of major incident management, this will probably be a game changer for major incidents once and only once the emergency services get on scene. The slight problem being, until they get there, as an event provider particularly, we might already have something in place, and then they click the button, and then all of a sudden what we have in place becomes a little bit less useful. I personally have some little notes on my EE account, so that when I speak to them and say, we have a situation here, I'm the event control manager at this event, and I really do need that 4G connection. I have a really strong antenna pointed at a particular cell. They will very kindly put a priority against my device and SIM on that cell, but only on that cell and only for a short period of time. Kaylin, yes, radios don't always work on structures and topographies. Fire and rescue have found out that tower blocks are just as bad as tunnels, and that using repeaters would perhaps be beneficial. So yes, don't always assume that messages can be sent and received. So interoperability is the way forward. There is very little interoperability in the UK between services. So if you are involved in any way, shape or form with search and rescue, you are able to communicate between Her Majesty's Coast Guard, the Royal National Lifeboat Institution and Mountain Rescue Services. And that's pretty much that group. If you are part of sort of the UK SAR network. So that includes urban search and rescue. It includes search and rescue helicopters. It includes mountain rescue teams. You're all able to communicate. If you are the fire brigade, you're all able to communicate with all the fire brigade resources anywhere in the country, as long as you're next to each other. But unless you happen to have a load of spare radios, you can't communicate with anybody else. Police and ambulance, depending, may have some shared talk groups they can use on airwave, so they can communicate together and they can communicate with their own services helicopters, but not with anybody else. And if it's a maritime incident, every Tom, Dick and Harry ship can communicate with the Coast Guard and the Marine Search and Rescue Resources, the RNLI and Coast Rescue, but not with anybody else. So that there do tends to be a lot of there is interoperability within groups, but there's not very much interoperability between those groups. ProMed does stand apart in that because we have pretty much all of the interop frequencies programmed into all of our management devices. They are very well heavily code locked, so it's very difficult if you manage to acquire one of our devices to find anything from it. You would have to do some very serious breaking into our devices, just for the record. But we do have interop to fire rescue. We do have interop to search and rescue. We do have interop to marine. Bizarrely, the only ones we don't have interop to are the police and the ambulance service, but that's because we don't do frontline work and therefore don't have airwaves. We obviously, when we work on events, have interop to all the services on events. So yes, Andy, comms between all services face-to-face, i.e. the JSIP, joint doctrine, face-to-face is the best way to do it. And that's why getting all of the emergency services to co-locate is the best idea. So when major incidents happen at events, the very best thing to do is to bring the emergency services into your event control room. You already have an event control room where people are used to looking at each other and talking to each other. So what you want to be doing is bringing the emergency services into that, because they're then bringing their communications network into the existing communication. So we have text-based messaging, so that can be data-based, for example, email or WhatsApp, or it can be SMS-based, such so your short messaging service, which uses probably the lowest bandwidth on anything. It's a very, very short. It is literally sent as plain text over the public cellular network. Text messaging generally gets through when calls can't. It generally gets through where data can't. So text messaging is really good. And again, at ProMed, we have a text number that goes onto one of our database services. So you can text your details to that number in the field, and that will just pop up as a ticket on our communications management system. So for those who've got online web browser access, they can be picking up all of those emails and dealing with all those messages without needing to have a single phone that is going beep, 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 and nobody's getting to read any messages because it's getting overloaded. We don't worry about that because we use a commercial third-party text message to web provider, if you will, and we can then work on them as individual threads with individual people working on each thread, and that works quite well for us. Don't forget, of course, you've got runners, so you're face-to-face. Remember, if you're using runners, don't give them a verbal message. You'll want to write stuff down. So this is where I was going back to the people on the scene doing the triage would write something on their pocket notebook. They could then literally fold that in half and give it to a runner and say, take this to the admin center. And then that runner just takes that piece of paper to the admin center. The admin center then processes that information. There is obviously a risk that that piece of paper could be lost. So perhaps take a photograph of it first, but runners are obviously great. And then, as I was saying before, we've got the cloud-based solutions. So as long as they've got some kind of offline caching functionality, cloud-based solutions can be good. We just need to make sure that everybody who has used a cloud-based solution before they sign off, before they finish, before they leave the incident, that they do have an internet connection, and that we have seen that whatever they were doing on a cloud-based solution has synchronized back into the cloud, so that it doesn't sit on their device for another 2 or 3 days because they've decided to turn their phone off while they decompress from the incident. So those routes, person to person. Now, person to person is arguably the best way, because if you go to the person you want to speak to with a message and you say it to their face and they repeat it back to you following safety critical communication protocols, then we know that message is being received. We know that message is being understood. and we can obviously hope that that information is then acted upon. We have messages going via an incident ground control. So at an event, this is generally the way it works. And that then just morphs into incident ground rather than being event control. So that is what is locally happening on the ground. The people responsible for making the decisions are physically there, and you're just routing all of your communications past them. We also have our service control rooms. So the police have a control room, fire have a control room, ambulance have a control room, Coast Guard have a control room, and so on and so forth. So there'll be messages getting passed between those control rooms, between the police and ambulance, between the police and fire, between ambulance and fire, and so on. There'll also be messages going between the service control rooms and incident ground area. There'll also be information going from service control rooms to individuals on the ground, from incident ground to individuals on the ground. And it can be very quickly and easily messed up. And actually, this is where the likes of RayNet become very good, because RayNet will produce a communications map at an incident, and they will say, right, if you want to talk to them, you need to send it via this route. And then everybody knows how information is going to flow through an incident. And that's something to try and establish early on. So if we go back to CSCAT, command, safety, communication. So communication is our third thing that we have to establish, and that needs to happen before assessment. If we have a communications plan, if we have some kind of procedure in place, if we have a method, if we have an aim, a policy, then we're not going to have duplicated information. We're not going to have communications going to the wrong people. We're not going to have people not finding out key information. We also have cross-border communication. So what I mean by that is, we have multi-agency support. So the casualty bureaus is cross-border between all the different police forces. If it is a large incident and the ambulance service is bringing in resources from a neighbouring trust, that's cross-border communications. Likewise, fire do quite a lot of mutual aid. When they have big incidents, they might bring in 2 or 3 neighbouring services to provide appliances directly to the incident. But it's also cross-border in the international sense. So if we have identified victims who are from another country, then the Foreign Commonwealth Office will be engaging with consulates from those countries, and that communication will be crossing borders in the sense of international. And it's important to remember that some of that information we're gathering from scene is going to be used in a much, much, much wider context than we might first envisage. So it's important that that information is accurate, it is legible, and it is something that can be used later down the line. Let me just get rid. So we're just going to little recap there. So tonight we've looked at from scene to safety. So we've kind of gave a bit of an overview of the complete patient journey and the different paths that they can take from where they were initially found in an incident to how they'll ultimately end up at home, or unfortunately become a fatality and end up with the undertaker. We've looked at the key ambulance service roles involved in patient tracking and what their different roles and priorities are and what they need to consider as part of their major incident responsibilities. We've looked at the different roles of the police force and police constabularies at a major incident with regard to patient tracking. We've looked at ProMed's rapidly deployable improvised solution that can start capturing data and start making sense of that information in that interim phase between emergency services arriving on scene and having their full solutions in place. We looked at how we're going to share that with them, and we looked at how we're going to input that information. We've looked at essential and useful information gathering. So what do we need to actually be able to identify patients and track them through the process? And we've looked at what would be useful to know from a clinical or from a demographic perspective. We've looked at the relevance of photographs for patient tracking and patient clinical care. And then we've ended by looking at the communication methods and routes for any patient information. So I'm just going to launch our next little poll. Just if you want to let me know what you thought of tonight's webinar and whether you would recommend ProMed and our webinars to your friends or colleagues. We do, of course, provide CPD certificates. So we have provided these webinars free of charge. And we are happy to give you a CPD certificate free of charge. We are going to verify that you were here throughout tonight's session. So if you do email us from an email address you didn't use with Zoom, or your name is not how you've appeared on Zoom tonight, please make sure you include that information in the body of your email so that when we check the register that Zoom gives us, we can make sure it is you. We are going to verify that you have left us a review, because we do, whether it's a 1-star, 2-star, 4-star, 5-star, whatever review, we would like some honest feedback. If you don't think that we've lived up to your expectations, if you're not rating us as satisfied or excellent, please do provide constructive feedback, because the more feedback you give us, the better we can make these for you. Once you've left us a review, we'll quite happily issue you with your CPD certificate. We're not going to withhold the CPD certificate if you give us a bad review. Don't worry about that. We just want some honest feedback. And then we will try and get them out to you within 3 business days. I do have an apology to make that last week's certificates took a little bit longer than that. You should have all had them today. So if you haven't, please just send us another email and we will check and we will get them out to you. If you have requested certificates for previous weeks and you didn't do that within a couple of days of that webinar, we do have a little backlog which we are going to try and clear tonight or tomorrow. So if you are still waiting for a certificate, please accept our apologies and we are going to get that sorted for you in the next 24 hours. So if you would like to review us, we are on Trustpilot, we are on Yelp, we are also on Google, and we are on Facebook. So if you've already left us a review on one of those, please leave us a review on a different one if you'd like your CPD certificate. If you have left us a review on all 4 of them, then you do get your CPD certificate anyway. We are very happy to do that. Thank you to everybody who has gave us feedback so far tonight. That's really, really good. We are going to move now on to our question and answer session. So if you do have any questions, first of all, please can you put something in the chat as a question. You can type it by text. You also have the raise your hand option on the participant panel. So if you raise your hand, we will ask you to unmute yourself. You can ask your question verbally. You can engage in a little bit of dialogue and we can have a chat rather than it just being a one-sided question and answer. We'll find the dialogue's been really engaging in some of these. And as you can see, we are putting up some of our future webinars on screen. So our webinars do run on Thursday evenings at 7 p.m. And we do have a few subjects lined up and we just want to know which ones are likely to be popular and which ones you want more of or which ones you want us to run sooner. So they are the emergency services, command roles, incidents, and that's all 3, well, all 3 core services plus some of the others. Filling out patient clinical record forms correctly. So if you're unsure of how to do that, you want a refresher, or if you work for different organizations, you want to know the general gist or where your kind of legal responsibilities are. We do have a session planned for the Jessup Joint Doctrine and Joint Decision Model, going into a lot of detail about them. Radio communications protocols and the demonstration of some common equipment. Safer recruitment principles and processes if you're the manager of a medical company. Safety considerations for medical providers at events and incidents. Safety critical communications protocols is something that I find is lacking, not just within the event sector, but also I've noticed it lacking within some emergency services sectors as well. And it is something that comes up in various inquiries and accident investigation reports quite frequently. The different roles and remits of pre-hospital care providers in the event sector, and that is the terminology from the multidisciplinary guidance. There's a lot of ambulance-specific terms that people don't understand. There's also a lot of event-specific terms that people don't understand, so we're going to really dissect those. The psychological impact of major incidents is something that we were requested to do, and working on TV and film production sets is something that we've been requested to do because we know a lot of medics with event experience are looking to do some film and TV work, but aren't necessarily sure kind of what happens on a TV and film set and who they need to interact with or how they need to behave or what the process actually is overall. So I can see quite a few thank yous coming through. So I'd like to say you're very welcome to everybody who is saying thank you. I'm just having a little scroll through for the questions there. You're very welcome. Our time, we don't mind spending this time and going through things with people. Our aim with these CPD webinars is just for everybody to gain a little bit of insight, a little bit of understanding, and some ideas to go away and have a little look yourself. All of our slides are available on our website, and if you look at the end of the slides, you have got full references for anything that we've been using to put these together. Some of those references are quite interesting. A lot of them are freely available. If they're not freely available, you can't find them, just drop us an email and we'll let you know where we can point you in the right direction, or maybe find a copy that you're able to access. Dita, yes, you're right. Some of the information is only applicable to the UK. I'm not an expert on international major incident management. but I am interested to learn. So if you do know of anything that's specific to your country, any webinars or anything, then please do let me know. And I'm happy to kind of learn about other countries as you have done by learning about the UK tonight. And yes, we've been using publicly available cloud services in our general business practice, and we just found a way that they would be useful should we ever come across an incident. I can see obviously we do have some statutory service commanders, SOT teams and so on. So thank you very much for attending tonight. If there's anything that you would suggest or do differently or have any thoughts, please do pop them in the chat. That would be great as well. So we do have a question there. So we've talked about tracking with emergency services and hospitals, and often on scene to get people like the Red Cross, and how would they fit into that? So they would generally fall under the service that has brought them in. So St John Ambulance and the Red Cross would typically be activated by the Ambulance Service NHS Trust, and they will be operating within the framework that they've hopefully practiced and rehearsed for. But if not, then they'll need to be briefed using II March when they arrive on scene as to exactly what we would expect them to do. So are we expecting them to write down a written record? Are we expecting to use them as the admin, as the logging volunteer? Because that is actually a really good role for somebody like that. St John and Red Cross first aid volunteers who have enough of an understanding to know what the triage categories mean and how to calculate a GCS and perform a blood pressure could be responsible for performing those duties. And if we give them a good briefing in terms of what we want them to write down. So it's just very service specific, I would say. It depends on who's brought them in and how they've been briefed. But if you are somebody who is going to be bringing those services in, or if you're an event provider and it's part of your overall event management plan, the time to think about how to use them isn't when the incident is happening. It's now in the cold light of day when you've got plenty of time to sit and think. The time to rehearse, again, the first time you do this is not when it is live, it is happening for real. The time to rehearse is when you've got some time, perhaps not doing a lot of, in-your-face training during COVID, of course, but, these webinars are great mediums for having these conversations. And when we do start to get into a new normal, then we can do some things together. We can do a lot of practice together. And that allows us to be prepared so that when the situation does happen, everybody knows what those roles are. So that was a private question I've just answered. Let's have a look. Let me just have a look at that Trustpilot link. There's a K missing off the end, admin team. You've not copied and pasted that link in full. If you have clicked on the Trustpilot link, please put a K on the end and it'll magically start working. Let's have a little look. Oh, admin team have corrected themselves there. Indeed, Alan, we do hope to provoke some thoughts. We are not aiming to answer every question. We're not aiming to give you a policy for your organisation or every incident that happens. What CPD is about is identifying for you where you want to discover more about your area of practice, or give you something where you go, I like that idea, but I actually want to make it my own, and you go away and you do your own reading and you draw your own conclusions. We're just the starting point after all. There's a lot of literature out there, and we always say that you should always go to primary literature yourself rather than relying on what somebody else has told you. Alexander, you're very welcome. So does anybody else have any questions? Please do raise your hand. I do like to hear other people's voices other than my own. I am sick of the sound of my own voice, if I'm totally honest. So if anybody does have any of their own questions, just raise your hand and we'll start a conversation, or just type them into the chat if you'd rather. Okay, PTS. So many services don't refer out loud to the body holding area. So P1, P2, P3, and P3. Yeah, and the black sheet. Yes. Yes, take them to the black room. They need to go next door. Yes, it is quite often referred to it. Yeah, P4, P0. It could be, yeah, P99. Different organisations have their own references. Take them to the waiting room, I've heard as well. So just be aware of those euphemisms that are being used. And again, in your II march, when you're talking about your administration, that is something that you will be discussing with people you're briefing face to face. Don't assume that everybody turning up to scene is going to know what you're going to call your body holding area, or if you've got a temporary mortuary, don't assume that everybody's going to know what that is. If you're using a non-standard word, make sure it's included in your briefings, because the last thing you want is somebody saying it out loud in front of a relative, or also you don't want somebody referring to it in the context that it's not supposed to be. Andy, you're absolutely right. Any bodies that are found on the incident site themselves stay at the incident site unless there is a serious risk to that body in terms of decomposition, destruction, burning, and so on. So if there is a fire that is encroaching on where that body is, then absolutely you can move them. Or if there is some masonry about a fall on them, they can be moved. But apart from those extreme severe circumstances, bodies are to be left where they are. However, once you've got the immediacy of triage out of the way, it is absolutely appropriate to perhaps get a blanket, a sheet, your black plastic, and cover that body out of respect. Remembering the dignity of that body should still be preserved as much as possible. Don't undermine services like St. John and Red Cross. They have years of experience in different incidents, absolutely. Some do regular frontline work at the moment, but at the same time, don't overestimate anybody's ability. I know some volunteers, but I also know some paid crews, paid event staff who are very new to the game, and it is very individualized. So when you are briefing people, ask them the questions. Have you been to an incident before? Have you done this kind of thing before? Yes. Okay. Are you happy doing this role? Yes. Okay. Let me brief you. No. Okay. If I give you this role, would that be better for you? Just remember, we are human too. We are not robots. As responders, we need to first and foremost look after ourselves. And then secondly, we need to look after our colleagues, the people who we work with, those around us, because we can't help the patients if we aren't taking care of ourselves. So our mental well-being, our welfare, our physical health is very important. So having those conversations. You're absolutely right. Throw in a question with jargon, see how they respond if you're unsure of their skill set. There are people out there who will talk the talk, certainly, but are unable to walk the walk. And checking people's ID, checking people's qualifications is as important at the scene of an incident as it is when you're allocating people on a roster at an event. You don't want underqualified people going into roles. You don't want inexperienced people going into roles. That being said, as things start to calm down at an incident, and you've got somebody who is absolutely grafted and you think would be good at a role, and what they're doing can be done by somebody else, why not get them to shadow you if resourcing permits that? I'm not saying you have to do that, and I'm not saying it's always appropriate, but ultimately the only way people get experience is to do that at the time and learn. Andy, yes, we have the BMJ books, the little A5 folder with the cards that comes with us to every event. That gets handed out. I have a Sharpie and I write inside the back of the folder who I've gave each card to so I can remember, because I don't want to get 30 minutes into an incident, know that I've got all my roles covered and not remember who's doing them. So yes, there was always a Sharpie that lives in that pack incidentally, as well as my own pocket. ProMed is looking into devising its own laminated A4 cards with some kind of placeholders for location, you are working as X, your name is, and so on. Yes, Pete, I agree. I wish Nauru would issue the major incident accident cards. That's what ProMed's going to be basing it on, those old Nauru cards, because I really do like them. And I know there are other medical providers out there that have started to put major incident packs together with each area, and it is something that for larger events that ProMed does. Obviously, we've not done any this year, which is why we've not pursued it. But for our larger events, that is something we want to have ready as a tabard, an action card, and some pieces of paper with information about casualty tracking and any other useful bits, so that you get given your folder. That's it. That's the pack you need to go and do your job. Anybody else got any questions, any thoughts, anything to discuss? Anybody want to raise their hand and stop me from talking? So we've got some private feedback there. Yes, so the Red Cross, so the British Red Cross can be different to the Irish Red Cross, which can be different to the Red Cross in Australia, which can be different to the Red Cross in Belgium, and so on and so forth. So I believe this person's from Ireland, and then they are integrated officially into that disaster response. But in other countries, they're not. And yes, patient tracking in other countries may not be the police. And then in some areas, they work with disaster victim identification on a day-to-day basis, as well as major incidents. However, others don't. Andy, thank you very much for your email address. I'll drop you an email tonight. That would be great. Apologies, you're from Belgium there. That's absolutely fine. Yeah, so in Belgium, the Red Cross work very closely with disaster victim identification on a day-to-day basis, whereas in the UK, disaster victim identification is something that is handled by the police, and different things don't. No plan survives first contact with the enemy. Yes, so if you do have an absolutely robust plan where you have thought about all the possible permutations, where you have discussed it with colleagues, where you have discussed it with other safety stakeholders, where you have tabletop various scenarios and you've used the outcome of those tabletop scenarios to develop your plan, that's absolutely great. If, however, you've knocked together your plan on a couple of sheets of A4 and have hoped for the best, yeah, it's not going to survive. So yes, test your major incident plans in practical exercises, not just tabletop exercises. You can do what's called a puke, a practical exercise without casualties. So you don't need to have 100 casualties pretending to be in various states of disembodiment, death, or screaming or squealing. You can do practical exercise without casualties. You can walk your event. You can, imagine what would happen if you had a stage collapse. You can imagine what would happen if a lorry drove through your fences and took out a load of tents in the middle of the night, and you can start to think about what would be compromised, and you can walk it through on the ground. You can talk it through with your colleagues, and if you walk it through and talk it through and you don't come up with any problems, you're lying to yourselves, you're kidding yourselves. If you can do a tabletop exercise and not improve your plan, then you've not done your tabletop exercise properly. If you do a practical exercise without casualties, and you don't have a whole sheet full of things that you would do differently, then again, you've just kind of done it to make yourself feel good. You've not actually done it to enhance your plans. So if you're going to do it properly, do it for the right reasons. Do not be ashamed to say, do you know what, my plan was rubbish and I'm going to rewrite that. The reason ProMed is got its plans the way it's got is because personally I've been writing plans for events for the last 7 years, and I've seen things go wrong, I've seen things go right, I've had input from the police, I've had input from ambulance service, I've input from fire, I've input from local authorities, and they've helped me develop as a person. They've helped me develop how I plan things, and it is that collective experience, that collective input, and it is those tabletop exercises that have then literally ripped those plans apart and almost made me cry. That has then allowed me to write a better plan, which is hopefully going to work. I'm not saying it is going to work. I'm saying it's given me the best chance of working, but it's because I've done it the right way, and it's because I've been honest with myself and gone, no, that's not going to work. It's not about validating yourself. It's about learning and exploring and coming to the right conclusions. Any more questions? Any more feedback? Any more thoughts? Discussion? Okay, as our numbers appear to be more or less the same, but we're not seeing much in the chat, let's just remind you all. So if you email webinars@promed999.co.uk with your full name, make sure that you tell us the name you appeared on in Zoom and the email address you registered on in Zoom if they're different, so that we can verify that you've been in this session throughout. We'll also verify that you've left us a review on one of our channels, and then we'll issue you with your e-certificate within 3 business days. We have provided the webinars free of charge for you, so please do leave us at least one review. We are on Trustpilot, we are on Yelp, we are on Google, and we are on Facebook, so any one of those sites would be great. Colin, Neil, indeed, we will see you next week. Annie, you're very welcome. We will leave the chat open for around about 10-15 minutes. We'll probably close it at around about 2050 to 2055. So if you want to click on any links, if you want to grab anybody's social media details or names, or if you want to look back through the discussion and make any personal notes before you do, we'll leave that up. But then we'll end the session probably just after 2050 this evening. Thank you all for coming along. I appreciate it, and I will see you all on Thursday evening at 7 p.m. When we're going to be looking at how to fill out patient clinical record forms correctly, legally, making sure that they are providing all the information you would ever need to defend yourself in court, but also all the information that the next care provider would need if they're going to take over the clinical care of your patient. So thank you very much, everybody. Stay safe and have a very good Thursday evening.